Well, good morning, everyone. Thanks for being here today, and I'm happy to be presenting to you. Those are two hard acts to follow, let me tell you, but I'll give you a little bit of my background. As you can see, I'm not 20-something anymore, and I'm in my 4th year of the PhD, not my 20th year. It hasn't taken me that long. But I decided to go back to school. I did many years as a researcher, as a master's level researcher, and I thought, geez, what an opportunity. I saw these young PhD students going through and how excited they were, and I saw the great program we had at Western, and so I decided to do some risk-taking and be vulnerable to what I did know and what I didn't know, and to go in and do my PhD, and I have no regrets whatsoever. So if there are people in the audience who are older, and I've thought, you know, maybe I shouldn't, maybe I'm too old, please just do it. It's been a wonderful learning experience. I've met some great friends. I've got some great colleagues, and I've been able to mentor some younger people coming through. So there's my story to share with you. But the other story that I wanted to share with you today is my area of work, which is totally different from what I've done for the last 20 years. So for a lot of the time as a researcher, what I did was take the things we did in our lab and try to move them into clinical practice. So when I decided to do my PhD, I thought, you know, maybe there's work out there that actually talks about ways to do this in a very scientific way. And that's what I would be interested in studying. And so what I found was a field called knowledge translation and implementation science. They're two newer areas. And specifically, I'm going to talk to you today about integrated knowledge translation, what it is, and how it can help the health sciences professions. And I would like to recognize that I have CIHR funding for my PhD work, and I'm well supported by the National Centre for Audiology and by Western. So the Canadian Institute of Health Research defines knowledge translation as a dynamic and iterative process that includes synthesis, dissemination, exchange, and ethically sound application of knowledge to improve the health of Canadians, provide more effective health services and products, and strengthen the healthcare system. It's a great definition. I wish I could come up with definitions as precise as that when I'm thinking about trying to define something. But the process of KT, so you can define it, but how do you do it? It takes place in a really complex system of interactions between researchers and the end users of their knowledge. So that could be clinicians, that could be patients, that could be other people, health policymakers, decision makers. And those interactions vary in intensity and complexity and level of engagement depending on the kind of questions that you're asking. So integrated KT, so there's different kinds of KT, but integrated KT talks about active collaboration. Active collaboration between the time you're going to ask a research question to the time you feel like you're solving it or putting it into clinical action. And it should enhance the development and clinical implementation of best evidence, resulting in treatment decisions that are more consistent with individual patient values and preferences. So we talk a lot in health sciences about evidence-based practice. And in order to really do evidence-based practice well, ensure that best evidence gets implemented, we need to have active engagement. So here's one framework that I've been using and which is widely used when we talk about integrated knowledge translation, and it's called the Knowledge to Action Process by Graham et al. And I'm going to walk you through the next few minutes, I've got 10:59 left, what this is and how I think it can help the health science professions. So as you know, the first component of any research project is to identify a problem. And really, one of the things that we found very helpful in the work that we're doing is to go to clinicians in the field and say, what kind of problems would you like us to work on? What do you need in your clinical practice to do work better? As you know, once you identify a problem, somebody has to do the work of reviewing and selecting the knowledge that's going to be reviewed from the literature. And we still have found that that's often best done by the researchers because we know how to do that and we have access to all the journals and all of those kind of things. So then you move to the point where you're going to create some knowledge. You're going to create the evidence that will impact clinical practice. So you inquire into the literature what knowledge is already available. You synthesize that, You bring it to a point where you're starting to funnel it down to try and come up with the best evidence or some answers to your question. And you really end up to the point where you actually develop what we call knowledge products. A knowledge product could be a clinical practice guideline. It could be some computer software to facilitate decision making in clinical practice. But that is funneling all that knowledge down to the point where you come up with some more precision. And really what you're doing at that point is tailoring the knowledge. Tailoring the knowledge so that it can be implemented into clinical practice. And that tailoring of knowledge needs active participation by the end knowledge users and by the researchers, possibly by the policymakers. We look at knowledge creation, so that whole funnel approach, as the social collaboration and negotiation of different perspectives. So it's not all about what is rated as the highest hierarchy of evidence. It's about active engagement and looking at different perspectives of that question and of the knowledge that you have obtained. And it looks at coming to a logical deduction that results in acceptance of a common result. And that acceptance of common result may not only be based on the highest level of evidence. The second component of the knowledge to action process is the application cycle. So not only do we have to create the knowledge to be used in practice, we need to know about the context in which people work that will in fact impact that use of the knowledge in practice. So different contexts will have different issues. You also need to know what are the barriers in clinical practice to the use of that knowledge, and what are ways that you might facilitate the use. And you only get an understanding of those two things by actively engaging with clinicians in practice. If you're going to implement this knowledge into practice, depending on what those barriers and facilitators might be and the context in which they work, you have to come to some conclusions on what implementation interventions might move that evidence into practice. Then you need to monitor the knowledge use. So that might be an adherence measurement or a fidelity measurement. But you also have to look at what outcomes, because when we talk about impacting health of Canadians or impacting health of anyone, we need to have some measurement that what we're doing in clinical practice actually has some benefit to the end user. But what I would argue is not do we only need to look at the patient outcomes, because the reason we put that evidence into practice is because we assume we're going to have good patient outcomes. But we also need to look at the implementation outcomes. So have we developed new skills in these clinicians? Do they feel, has their self-efficacy, their belief that they can do this practice improved? Do they have, is it better than what they did before? So do they feel that it's better than the procedures they used before? So there's implementation outcomes and patient outcomes. And we need to think about how we're going to sustain that knowledge use. Because the biggest issue in applied health sciences is that there's always something new coming down the pipe. There's always some new evidence that's coming that needs to be put into practice. So if we want clinicians to continue to do something we have agreed upon is best evidence and best practice, we need to develop methods to sustain the use of that knowledge in practice. The other important component to this whole framework is that these two things, the creation of the knowledge and the application cycle, don't have to occur separately from one another. In fact, if you think about integrated knowledge translation, they should be occurring simultaneously in a lot of cases. When you're developing the evidence and you know what is coming down the creation funnel, you should already start to think about what are going to be the barriers to putting this into practice. And if you think about that up front, you actually move that evidence into practice faster. So what is the value of this for the health sciences professions? And in my PhD work, along with another PhD student, Marlene Bagato, we've been working with this integrative framework to develop some outcome measures for pediatric audiology. And we've found some great value for pediatric audiology in using this approach. Well, what it does is it facilitates the knowledge creation cycle by utilizing an engaged community. And the audiologists that we've been working with across the country feel engaged in what we're doing. They feel involved. And they're the only ones who really know about the barriers and the facilitators and the context in which they work. We can make some predictions or some assumptions, but we don't know. We're not working where they're working. We're working in our laboratories. And by interacting with them, they're feeling engaged and heard and listened to. It provides an opportunity to include tacit knowledge. And a lot of people will think about this, but experienced practitioners know how to do things. They don't always write it down, but they know how to do things. And by engaging them in the process of creating the knowledge and looking at the barriers and how we might implement it into practice, we get some of their tacit knowledge coming through to help us move this into practice. It also facilitates the development of appropriate knowledge products or resources, not only for really experienced practitioners. So a lot of the time when we're developing research for clinical use, we involve experienced practitioners. But experienced practitioners know how to do a lot of things. If we also include novice practitioners, we'd be able to fill the gamut of moving this evidence into practice. And only practitioners know how to grease the implementation wheels and provide a roadmap to the potential minefields inherent in attempting to introduce change in any organization. And so by partnering with these people, we actually have great resources on how we as researchers will get this evidence used in practice at an organizational level. So that's my quick little talk for you today, and I'm happy I will be around today. And I'm just up in the National Center for Audiology if anyone is interested in talking about this more. Thank you very much.